So this talk was meant to be given by Gabriella Webb, who is a postdoc in my lab, but she is expecting a healthy baby boy next month, and so obviously did not want to travel across the ocean, and so I'm standing in for her. And so on behalf of Gabby and myself, I'd like to thank the organizers for the opportunity to present this work. I'd like to thank George for that great talk because he actually opened my talk initially, and I laughed because he could have given this talk. So George's work has really set the stage for IL-15 because he's the one who really revealed the basic biology of this. And you could summarize this talk in one sentence, which is, we see the exact same thing. Well, there is one difference, and that is the actual compound that we use, which is called Alt-803. It's a human IL-15 superagonist complex. It's manufactured by Altor Biosciences. It is a human IL-15, but instead of using wild-type IL-15, it uses a mutant version that has a substitution at position 72, and this gives it about 5 to 10-fold higher activity than compared to wild-type IL-15. That's then fused onto the IL-15 receptor alpha, and 2 of those heterodynamic units are then fused to the human IgG Fc receptor. And this gives Alt-803 a longer biological availability and is a very superagonist. It's very potent in vivo. So as George said, and has been published previously, it induces massive proliferation in natural killer and memory T cells. In our hands, it's been very well tolerated in non-human primates. And because of this, we haven't seen any deleterious effects. It's in multiple clinical trials for solid and hematologic cancers. More recently, it's gone into a phase 1 clinical trial for HIV, where they're looking at the University of Minnesota to see if it can disrupt the latent viral reservoirs. And so in our hands, it works very well. We see the exact same thing that George said. You see very high proliferation and activation of NK cells and memory T cells. And by BRDU studies, we've shown that those T cells, activated cells, leave the bloodstream and they home into the lymph nodes. And so here we're looking at disaggregated lymph nodes, just looking at the frequency, looking at, in these animals, pre-Alt-803 treatment in the lymph node, in the filled circles, and on the right in the open circles 5 days post-treatment. We really don't see a big change in the percentage of NK cells in the lymph node. We see a slight decrease in the percentage of CD4 T cells, and that's not because they're leaving the tissue. It's actually because there's this absolutely massive influx of CD8 positive T cells, which you can see here. As was alluded to, one of the major clinical findings that we see in these animals is always marked lymphadenitis. The lymph nodes are absolutely swollen. It's really remarkable to see, and that's because they're chock full of CD8 T cells. In vitro, when we treat the CD8 T cells with Alt-803, what we saw was that they actually upregulate mRNA for CXCR5, which is the homing receptor for the B cell follicle. So shown here on the left, you can see they upregulate mRNA, and then on the right, that's involved with a commensurate increase in surface expression of CXCR5 on the surface of these cells. And because we saw this, we collaborated with Pam Skinner at the University of Minnesota, and we decided to look in the lymph nodes by in situ MHC class 1 tetramer staining, and this is just an example of what we see. So this is looking in the lymph node of an animal. You can see on the far left, the B cell follicle is demarked by staining with CD20 in green. And then you can zoom in on that in the middle panel, and we're looking by CD8 in blue and then SIV-specific cells in red. Those are tetramer-positive cells. And I'll direct your attention to the right panel because that's really where all the action is. It's probably hard to see, but this only shows the tetramer-positive cells, and they're marked with white arrows. And as people have described previously, you see most of these cells excluded from the B cell follicles. Some do traffic in, but it's not many. In contrast, post-Alt-803, you see some interesting things happening. You can see that on the left and middle panels, there's significantly more blue staining because there's more CD8 positive T cells that have trafficked into this tissue. If you look on the far right at the SIV-specific tetramer staining cells, this is CM9 in this particular animal, you can see that overall there's just significantly more of them in the lymph node, as George also shows. Really impressive. But these also traffic into the B cell follicle, and not only that, but they seem to traffic much deeper into the B cell follicle than what we see pre-treatment. And so these IL-15 superagonist compounds, it doesn't seem to really matter which one you use. They all seem to do the same thing, and that is they take your cytotoxic T cells, send them to the B cells, and specifically into the lymph node, and specifically into the B cell follicles. And so what that says is that this is probably Alt-803 and heterodimeric IL-15 are really potent compounds, either by themselves or together with other compounds for latency reversal and shock and kill approaches. So with that, I'd like to thank the people who did the work. It's Gabriella Webb in my lab who fortunately couldn't be here. I'd like to thank Sheng Bin and Guantua in Pam Skinner's lab at the University of Minnesota who made those beautiful pictures. And as a shameless plug, Sheng Bin is actually looking for a postdoc. So if anyone's interested in someone who can make beautiful pictures, please contact him. Thank you.
Questions?
Hi, Jason.
Did the IL-15 lead to reduced frequencies of infected TFH cells?
So we collaborated with Liz Connick, and she looked by RNA scope. And yes, there was reduced frequencies of RNA-positive cells in the follicle.
Is that all? So most of the follicle RNAs is actually FDC trapping a virus. That's not necessarily infected.
Yes,
CD4 positive.
these were CD4 cells.
I see.
Hello. So did either you or George see any regulation of your checkpoint inhibitors? Or was there specific checkpoint inhibitors that may have been downregulated or changed in the IL-12, IL-15 treatment?
We didn't actually look, so I'll pass that over to George, see if he looked.
PD-1 goes up, as you expect. You push the cells for more towards effectors. In mice that we have done a lot of tumor models, and we have published some of this data in CCR recently, you see that although in general you have an increase in PD-1, if you look intratumorally, you have lower levels, positive but lower levels per MFI of PD-1 in the presence of IL-15. So it looks like when the cells are proliferating, maybe you also affect the PD-1 levels.
Do you know anything about the other checkpoint inhibitors? The other checkpoint inhibitors?
We're looking into several of those now.
I have one more question. Have you looked if you have more IL-21 secretion after?
We have not. We have serum banks, so we can definitely do that.
Thank you. Thank you. So we need to move on to the next speaker. So our next speaker is Tianhu He, and she's from University of Pittsburgh School of Medicine, and the title of her talk is Tissue Factor Pathway Inhibitor Xolaris Improves Disease Outcome in Progressive SIV-Infected Pigtail Macaques.
Thank you very much. Good afternoon, ladies and gentlemen. I would like to thank the organizers for giving me this opportunity to present our work here today. So in recent years, it has been observed that there is a hypocoagulable status in the HIV-infected patients marked by increased D-dimer levels in their plasma. A few years back, our lab also confirmed this finding in our pathogenic non-human primate models with increased D-dimer in chronic SIV infection. Interestingly, these pathogenic non-human primate models also exhibit high levels of immune activation and inflammation after SIV infection. So it has been proposed there's a link between hypocoagulation and immune activation and inflammation. However, the exact mechanism of that is not directly tested or confirmed. Previous studies have shown that tissue factor may be an important player here. In this study, we also found that in the pathogenic non-human primate model, we had the pigtail macaques. There is an increased tissue factor expression on CD14 monocytes during chronic SIV infection, and it remained unchanged in the non-pathogenic model African green monkeys. And upon LPS stimulation, there is a significantly higher tissue factor expression on the monocytes of pigtail macaques compared to African green monkeys. And this is, we got the similar results when we measured the tissue factor levels in cell lysates, and also when we measured the tissue factor activity in forming factor 10A. And this is not only true in the blood, but we also see in the late chronic SIV infection, there is high level of tissue factor expression in the mucosal tissue in both lamina propria and pious patches. And this is not surprising because in the pathogenic non-human primate model, they also have microbial translocation. And the LPS that translocated from the gut lumen could induce the tissue factor expression increase that we're seeing here. So to directly test if tissue factor is indeed the key player in bridging hypercoagulation, immune activation, inflammation, we thought to use a specific tissue factor pathway inhibitor, Ixolaris, to block the tissue factor activity. So first of all, we wanted to test its specificity in inhibiting the tissue factor coagulation pathway, also known as the extrinsic pathway. So here on the upper panel, you can see that after Ixolaris is added to non-human primate plasma or human plasma, it specifically prolonged the extrinsic pathway indicator, PT, which is prothrombin time. And it has minimal effect on the intrinsic pathway indicator, APTT, which also known as activated partial thromboplastin time. So it indicates it's specific for the tissue factor pathway. And after that, we moved on to administer Ixolaris in vivo in the pathogenic model that we had, the pigtail macaques. So in the Ixolaris treated animals, marked in red here, they have a significantly lower level of tissue factor expression on CD14 monocytes. And they also have decreased IL-17, which is a pro-inflammatory cytokine, and reduced HLA-DR CD38 expression on the T cells, especially CD8 T cells during chronic infection, indicating a reduced immune activation of the T cells. And not only that, they also resulted in reduced monocyte activation marked by CD80 and CD86. Importantly, these Ixolaris-treated animals had lower level of D-dimer in their plasma during acute infection compared to the controls. And last but not least, Ixolaris has an effect in improving the survival of these progressively SIV-infected pigtail macaques, with none of them progress to AIDS within the first 100 days of infection, which is rather rare according to our experience. To conclude, we show that tissue factor bridges hypercoagulation and immune activation inflammation during the chronic SIV infection. And specifically, blocking tissue factor using Ixolaris improves the clinical outcome of this progressive SIV infection. And what's important is with these findings, we add in a new player, a very important player in the HIV-SIV pathogenesis, that is hypercoagulation. It not only can exacerbate immune activation and inflammation and forming a vicious cycle with it, it also can directly contribute to the comorbidities. Therefore, it is a very important issue to address when we're combating chronic HIV-SIV infection and non-AIDS comorbidities in the post-R era. So with this, I would like to thank everybody in the Apotropandria Lab and our collaborators from NIH, University of Vermont, and University of Lisbon, without whom this study won't be possible. Thank you very much.
So as I'm sure you know, pigtails often get thrombocytopenia, which is associated when they become SIV infected with clotting, probably attributed to tissue factor. Did you count the number of platelets in the pigtails longitudinally? Did the treated animals have higher numbers of platelets or were available to be counted?
So when we were doing this study, we haven't started counting the platelets in our pigtails yet, but we are doing it now in the new studies with other anticoagulant therapies. And what's interesting is, so our lab have several models. Pigtail is one of them, and rhesus macaques and African green monkeys. And the pigtail macaques actually had a higher amount of platelet in their plasma, and it's increased after infection. Although we did not measure, so we're in the process of measuring the activity of these platelets and their activity after we administer the anticoagulant therapy, but please look forward to those results.
So I have a question. So you have looked at, so you have a decrease in IL-17.
Yes.
And so have you looked at other subsets, CD4 subset, like immunoregulation? Is it, does it go through regulatory T cells, for example, or have you looked at other T cell subsets?
Yeah, so we have the flow data for those other T cell subsets, including Tregs, but we didn't see a significant effect as we saw in the just general CD4 and CD8, the immune activation of those general populations.
Okay, thanks, Emma.
Thank you.
One more question?
Okay, thank
A
you.
quick one.
Yeah, do you think this effect is maybe thrombin dependent? What happens to PAR1 signaling and things downstream of that pathway?
Yep, so in our lab, we also used other anticoagulant therapies which targets, we used the thrombin direct inhibitor, which is dabigatran, and we also in the process of assessing a PAR1 inhibitor. Unfortunately, those anticoagulant therapies did not work as well as tissue factor inhibitor, and it would be very interesting to dissect the mechanism of this.
So could I ask you, could you speculate on where you think this extrinsic pathway activation of systemic immune activation takes place?
We speculate that it could be we originally thought it was through PAR1 signaling, but unfortunately the PAR1 inhibitor we're using now is not working great. So we're thinking it might be the effect of actually factor 10, and that could be an explanation, but Dr. Sverdi might explain better than me on factor 10.
Well,
Yeah, we'll see.
well done, Emma. Thanks.
Thank you.